I am Dr. G Sridhar, Chief Consultant Nephrologist and Kidney Transplant Physician, Global Hospitals. If we see the trend in the chronic kidney disease, especially chronic kidney disease means like irreversible decrease in the kidney function. Once if it reaches the late stage like CKD, chronic kidney disease stage 5, the patient requires either permanent lifelong dialysis or kidney transplantation or peritoneal dialysis. The number of people suffering with this disease is increasing day by day. It is increasing globally as well as in India. The most of suppose if we have around 100 patients of chronic kidney disease, in them 60 to 70% of the patients are because of uncontrolled diabetes mellitus, that is sugar, or uncontrolled hypertension. So the people affecting with diabetes and hypertension also increasing, and in the same way it is chronic kidney disease also parallelly increasing. And most of the younger patients, like at the age of 30 years, 40 years, people are coming with obesity, hypertension and diabetes, and uncontrolled these factors leading to chronic kidney disease at the age of 40, 45 years also. Generally if we see, if for any kidney transplant, once any person's kidney function decreases to less than 10%, normally kidney filters around 80 to 100 milliliter of blood per minute. Once if this kidney function decreases to less than 15 ml per minute, that is and it is irreversible damage, that is the time patient needs transplantation or lifelong dialysis. So once transplant, traditionally first criteria for doing the kidney transplantation is there should be a match between the donor blood group and patient blood group. Suppose A positive recipient is there, so donor has to be A positive, or O positive can be given to any blood group. They are called as universal donor. This is traditionally, like till now we are doing. This is called as a compatible transplant. But the problem with the kidney transplantation is, out of 100 patients suffering with the kidney failure who require transplantation, kidney transplantation is the treatment of choice, but only 3 to 5% of the patients are getting this kidney transplantation. Remaining 90 to 95% of the patients are on either lifelong hemodialysis or lifelong peritoneal dialysis. The main reason is lack of donors. So, and even sometimes family willing donor may be there, but their blood group is not matching. So, in recently, like last 10 to 15 years, blood group mismatched kidney transplantations also we are doing. Earlier, like if you see 10 to 15 years back, it is associated with lot of procedure before transplant and results were not that much good. But now science has developed where even non-blood group matching kidney transplantation also we are doing in a simple way, just 3 to 5 sessions of plasmapheresis followed by 1 injection of rituximab, and post transplantation compared to the compatible donor, first 1 month there is increased risk of rejection around 3 to 5% more than the compatible donor. Once after 1 month, if even a non-compatible donor also, if it kidney takes for 1 month, and if you manage the 1 month of the post transplant period, results are almost equal with the compatible donor. After 1 month, there is no difference between the compatible and non-compatible donor recipient. Whereas in first month or before doing the surgery, these patients require special therapy plasmapheresis and injections rituximab, and sometimes after post transplant they may need another 3-4 sessions of plasmapheresis and rituximab injection. So their cost goes more than by another 40% than the compatible transplant, slightly 3 to 4% increased risk of infections compared to the compatible donor. But after 1 month, 4 to 6 weeks of post transplant, the life is almost same in both the patients. But only disadvantage is like 3 to 5% of the patients, if they develop hyperacute rejection, they may have to go back on dialysis or for second transplantation in the future. If the patient is not having blood compatible donor, there are 2 options are available. One is either they have to go for the non-compatible ABO incompatible transplantation, or best option is the swab kidney transplantation. In swab kidney transplantation, what we do is, suppose one patient A, his blood group is B and his donor is A group. In the same way, other patient blood group is A and the donor is B group. So, both the families are getting benefited here. First family donor will give to the second family and second family donor will give to the first family. So, we call it as a swab kidney transplantation. So, by encouraging this swab kidney transplantation or this incompatible transplantation, ABO incompatible transplantation, so we can increase the number of patients going for transplantation, which is the treatment of choice. And apart from these two, cadaver transplantation, like encouraging cadaveric transplantation, educating the normal people about the organ donation, it helps to improve the cadaver organ transplantation. So, these three are the options. If compatible donor is not there, either going for cadaver waiting list and going for cadaver transplantation after 6 months or 1 year whenever they get the choice, or going for ABO incompatible transplant, or going for the swab kidney transplantation. Now, there are around only 3 to 4 centers started doing ABO incompatible transplant now. And in future, if you see Japan, where around 30 to 40% of the transplantations are ABO incompatible transplant, and compared to the 10 to 15 years back, now whatever the treatment we are giving is simple and safe. So, maybe in another 5 to 10 years, as we gain experience of ABO incompatible transplant also, this process may be simplified again. Instead of 3 or 4 plasmapheresis, 1 or 2 sessions of plasmapheresis, and minimizing the dose of rituximab also may happen.